Okay, so this lecture today is going to look at some of the treatment modalities for ischemic stroke. So any objectors are, there's very few of them. There's only 2 drugs in this particular lecture series. I do want to point out this is an interesting link to the American Heart Association, American Stroke Association joint 2018 guidelines for the treatment and management of ischemic stroke. It's a light read. It's only 280 something pages, but the bulk of this material is kind of summarized from that. So of course you know what a stroke is. It's reduction in blood flow, and it was basically due to a clot. And so there's different types of infarcts depending on the size and the location of the vessel and where the potential ischemic level came from. But understand that stroke is becoming more and more common. Usually 200,000 patients die yearly from strokes, and it's now becoming the 5th leading cause of death here in the US. And so the management or the therapeutic strategies are nicely summarized here. Of course, we want to reduce the ongoing neurological injury. We would like to decrease mortality, and of course prevent brain damage and prevent another stroke from occurring. And so in terms of the drugs that can be used to treat ischemic stroke, we're really looking at IV administration of Alteplase. Okay, and this is immediately, so we'd like to give this as soon as possible. Right now, the kind of window of opportunity says within 4 hours of an ischemic stroke with demonstrated neurological deficits. Okay, other indications demonstrate that in order to give this drug, the blood pressure absolutely must be lower than 185 on the systolic side and lower than 110 on the diastolic side. And of course, the patient should be older than 18 years of age, and if female, not pregnant. Okay, so if the blood pressure is higher than this kind of minimum cutoff value of 185 over 110, you should consider stabilizing the patient, of course, and treating with labetalol or nicardipine. These 2 have been named within those 2 guidelines as being 2 quite beneficial drugs to kind of lower blood pressure to this target rate before Alteplase therapy can be initiated. So what is Alteplase? Well, we give it acutely. I want to highlight that. And from a mechanistic standpoint, it's a recombinant protein/enzyme, specifically a serine protease, that cleaves proteins, specifically proteins associated with the fibrin molecules. And this particular drug has been shown to be more efficacious than its grandparent, streptokinase. And so for a variety of reasons, I removed some of the older drugs from this lecture series because they're just not used anymore. Streptokinase, of course, has bacterial roots and has been associated with an immune reaction. So we typically don't use it. Alteplase is the recombinant version of that protein/enzyme, and it's been genetically engineered or biologically engineered. You don't really get an immune reaction from it, and the outcomes are much better. So Alteplase is really kind of the star player in this ischemic stroke show. In terms of its half-life, it's got a really short half-life, anywhere from 5 minutes to 30 minutes, depending on the patient, and of course this is administered IV. And it's been shown to be very effective when given as close as possible during or when the stroke has occurred. And so kind of the ballpark timestamp on this is 4 hours. And you need to confirm with imaging studies to show that there's no active bleed. If there is an active bleed in the brain, that's the biggest contraindication to using Alteplase. Okay, and as I said, later generations of Alteplase, including Retoplase and Tenecteplase, have a much higher affinity. They've got longer half-lives, they're more potent, they're associated with more side effects, and they also cost more money. Okay, and so all of them have this similar mechanism of action. We're really today going to focus on Alteplase because it's the one most commonly cited in clinical trials. The major side effects, of course, include systemic bleeding, especially at kind of the higher doses, and then the fact that you must monitor blood pressure before, during, and after administration of this drug. Here's a nice kind of summary diagram of how these fibrinolytic drugs work. We haven't gone into a lot of the coagulation pathways and cascades. We're going to reserve that for next year. So this diagram is overly simplified, but it's relatively simple anyway. So you've got a patient who had a stroke, MI, PE, and all of this results from a clot, and from a physiologic standpoint, you get low oxygen perfusion. And so what we do is we capitalize on the body's kind of innate control mechanisms, and we try to force this clot to be dissolved. And we can do this by activating the fibrin degradation pathway, which will restore oxygen perfusion. And in order to activate this pathway, we kind of have to go a little bit up further here, and we have to provide these fibrinolytics, such as Alteplase or TPA, to basically convert plasminogen into plasmin, and plasmin assists in this activation pathway. And so when fibrin becomes degraded, that clot gets broken down, and the affinity for Alteplase for this plasminogen component is very, very high. And so that's why you can look in the literature and you can see these drugs labeled as clot busters. So they're administered IV, they go in, they find the clot, and they activate this pathway, and they start dissolving the clot immediately. So of course there are complications to Alteplase therapy. Bleed outs are the most highly cited complication. Angioedema can occur as well. Some patients do experience breathing complications or airway obstruction, and so obviously these patients need to be monitored quite aggressively and closely while this drug is being administered. There are contraindications to Alteplase, and so if the patient has any of these either diagnoses or any of these events within their history, Alteplase should be avoided, and perhaps something like thrombectomy can be performed, and that would be discussed in another discipline and in another lecture. Now, if the patient is given Alteplase and they start to experience an active bleed, if they complain of a severe headache, if they're conscious, of course, if they demonstrate acute hypertension or a worsening neurologic exam, or start becoming nauseous or vomiting, then Alteplase should be immediately stopped. And so the other drugs that we can talk about for the management of stroke include aspirin, which is really well given within 48 hours. And so there's kind of a two-dose component here. Within that 48-hour time period, you see higher doses given initially, and then once the patient's essentially stable and is going to be released, you can see them being put on kind of that maintenance low-dose aspirin therapy. And then the other group of drugs that are really important for the management of stroke patients include statins, specifically atorvastatin, and that was based on a clinical trial. From a mechanistic standpoint, I'm sure you guys all know how aspirin works. It's a COX-1, COX-2 inhibitor. At the lower doses, we tend to favor the COX-1 enzyme, which is specifically found on platelets. And then statins are kind of I say the silver standard because they're second only to aspirin. Officially, they inhibit HMG-CoA reductase and they reduce serum cholesterol levels. Atorvastatin specifically was mentioned in the stroke literature because of the Sparkle trial, and you can look up that information if you so choose. But essentially what this demonstrated was that specifically atorvastatin, when given in high dose, was an excellent therapeutic for both the prevention of stroke to occur, but also in the prevention of secondary stroke. And secondary stroke basically just says that any patient who's had a stroke has a much higher risk of developing another stroke. And that's really due to these comorbid diseases, hypertension, hyperlipidemia, atrial fibrillation, and others. And so treatment of these diseases requires aggressive anticoagulant therapy, as well as aggressive approaches to treating those individual diseases. And we've talked about these diseases in various components of the curriculum. Atherosclerosis, high LDL, low HDL, we're looking at intense statin therapy, and atorvastatin 80 milligrams was suggested. Hypertension, we can go after ACEs and ARBs and beta blockers. Patients that are hypercoagulated will be on some of the anticoagulants that we haven't really talked about in great detail, and we're going to reserve all of those drugs for next year. We don't need to do coagulation on top of neuroscience. That would be crazy. Okay, so we'll come back to some of these anticoagulants and we'll examine some of these nuances with all of these different diseases. Also understand that what we've been talking about this whole 10 minutes or so has been ischemic stroke. There is a hemorrhagic stroke, and it's obviously a little bit different. It's less frequently encountered, and it's the result of an active bleed in the brain. And the goal is now to stop bleeding. And we can do that with mannitol, which is a diuretic, or an anti-seizure medication, both of which will be covered in other blocks. Okay? So that's an overview of ischemic stroke treatment. If you have any questions, please email.